speak on is IPAP an incompletely evaluated UCTD with ILD, Indian and global data. I am not to declare. I will discuss under these headings: nomenclature of IPAP, undifferentiated CTD associated ILD and not cell, global data on IPAP, Indian IPAP cohorts, is IPAP a distinct entity, and my take home message. So, IPAP, suggested term by the European Respiratory Society, American Thoracic Society, for recognizing individuals with interstitial pneumonia and autoimmune manifestation. What was the need of such a classification? Up to 1/4 of patients with systemic autoimmune feature do not fulfill classification criteria for defined CTDs, and interstitial pneumonia patients can have autoimmune feature. How would one evaluate such a patient? Existing criteria for UCTD ILD were heterogeneous. These criteria were variously named as undifferentiated CTD associated ILD by Kinder et al., long dominant CTD by Fisher et al., autoimmune feature ILD by Bees et al., undifferentiated CTD by Cotte et al. These criteria required presence of an interstitial pneumonia, exclusion of alternative etiologies, not fulfilling criteria for a defined CTD. The Fisher et al. Criteria did not include clinical features, whereas Kinder et al. And Bees et al. Criteria and Cotte et al. Criteria included Raynaud's, arthalgias or arthritis, Zika symptoms, proximal muscle weakness. In addition, Kinder et al. And Bees et al. Criteria also included certain clinical features, which were considered less specific by Cotte et al. The autoantibodies included in this criteria were slightly different. Kinder et al. Included ANA, anti-SL70, SSA or SSB, Jo1, rheumatoid factor, inflammatory markers. Other criteria, some considered ANA at a certain titer, and addition of other autoantibodies like anti-RNP, anti-tRNA synthetase, anti-Smith, anti-PMSC, addition of anti-CCP. Morphological criteria were included in Fisher et al. So Fisher et al. Was more of objective criteria, Cotte et al. Was more specific, whereas Kinder et al. Was least specific. And when these criteria were applied to a cohort of 119 patients with interstitial pneumonia, at least 56% of patients fulfilled at least one criteria, whereas 18% of patients fulfill all criteria. With the least specific Kinder et al. Criteria, 43% were labeled with UCTD with ILD, and with Cotte et al. Criteria, 21% of patients labeled as UCTD. So this led to the formulation of IPAP classification criteria by the American and European Respiratory Society. The entry criteria were similar to the previous criteria. The criteria required at least one feature from at least two of clinical, serologic or morphologic domain. So the clinical criteria included systemic sclerosis features like distal digital tip ulceration, palmar telangiectasia, Raynaud's and poppy fingers, and myositis features like mechanic hand, Gordon sign and arthritis. The serologic domain include anti-nuclear antibody at 1:320 titer, but no titer required for nuclear or a centromere pattern, rheumatoid factor anti-CCP, autoantibodies specific for systemic lupus like anti-dsDNA, anti-Smith, myositis specific antibodies anti-tRNA synthetase, and other autoantibodies like Scleroderma antibodies anti-SL70, anti-PMSL, anti-MDA5. The morphologic criteria included suggestive radiology patterns on HRCT, on surgical long biopsy, and multi-compartmental involvement. The presence of UAP pattern on HRCT was not given credit, and for a classification of IPAP, at least one feature from the other two domains, clinical and serologic, required for IPAP classification. So, coming to the characteristics of UCTD ILD patients, a study of stable UCTD patient with a median disease duration of 6 years, with a median age of 40 years, predominantly females, reported NSAP pattern HRCT in 7% of patients. Besides arthalgia, arthritis, Raynaud's, Zika symptoms were also common. Anti-nuclear antibody was present in 100% of patients. Anti-SSA antibody was reported in 19% of patients. So, is idiopathic NSAP the long manifestation of UCTD? Kinder et al. In a study of approximately 30 patients, he observed they observed majority of patients with a diagnosis of idiopathic NSIP fulfill classification of UCTD, and these patients more likely to have ground glass opacity on HRCT and NSIP pattern on biopsy. Another study from China reported HRCT findings of ILD patients. They included almost 60-70 patients in each group: CTD-ILD, UCTD-ILD, and IPF. P1 is a comparison between CTD-ILD and IPF. P2 is the comparison between UCTD-ILD, CTD-ILD, and UCTD-ILD. CTD-ILD and IPF. P2 is CTD-ILD and IPF, and P3 is UCTD-ILD and IPF patient. So look at the last column. None of the HRCT findings, the consolidation, ground glass opacity, traction bronchiectasis, honeycombing, these features were not different between IPAP and IPF patients. Traction bronchiectasis and honeycombing were not different among the groups CTD-ILD, UCTD-ILD, and IPF. However, consolidation, ground glass opacity were significantly higher among CTD-ILD or UCTD-ILD patients. So UIP pattern can be seen in UCTD-ILD patient. So coming to IPAP cohorts, global data, the Chicago pulmonary cohort, it reported a prevalence of IPAP 34.1%. Interestingly, approximately 20% of patients who previously classified as IPF, they fulfilled the IPAP criteria. 91% of patients fulfilled serologic domain, Raynaud's, arthritis, mechanic hand were common. The cohort included 54% of patients with UIP pattern. They also looked at survival. The survival of IPAP patient was slightly better than IPF patient, but it was significantly worse than CTD-ILD patient. But when they stratified based on UIP pattern on HRCT, IPAP patients with UIP on HRCT behave similarly to IPF patient. Those without UIP pattern were similar to CTD-ILD patients. So in their cohort, compared to UCTD-ILD, patients were of older age with higher frequency of ever smoker and UIP pattern on HRCT. The French pulmonary cohort, it reported a prevalence of IPAP 7.3% with a mean age of 64 years. Majority fulfilled the serologic domain. Raynaud's and arthritis were common clinical features. NSIP and UIP pattern HRCT were seen in 53% and 28% of patients respectively. Survival not different than IPF. They attributed it to inclusion of patients with UIP pattern on HRCT. And the cohort also reported autoimmune features which are not listed in the IPAP criteria. Zika symptoms were seen in 30% of patients. Gastroesophageal reflux disease in 7% of patients. Abnormal nail fold capillaroscopy in 43% of patients. And positive minor salivary gland biopsy in 14% of patients. The Colorado rheumatology cohort included predominantly females who were non-smoker. Most fulfilled the morphologic domain, and Raynaud's and mechanics hand were the common clinical features. Anti-nuclear antibody was positive in 48% of patients. Anti-tRNA synthetase was positive in 36% of patients. And most common radiologic patterns: NSIP, NSIP to OP. Immunosuppression was used in all patients, and the cohort reported a good prognosis for the patients. The Athens rheumatology cohort included 39 patients with a mean age of 63 years, predominantly females. Arthritis was seen in 82% of patients. They reported morbilliform and or polymorphic rash in 54% of patients. And the most common radiologic pattern was reported NSIP. They also reported infection, particularly common in the first semester of treatment. There are two prospective IPAP cohorts. The clinical characteristics are resemble the retrospective cohort with predominantly females with the age group in 60s, ever smoker over 50%, majority fulfilled the morphologic domain. However, in the study by Sebastian et al., 44% patient had UIP pattern on HRCT. And when these patients were followed up over a median duration of 30 months, 7 patients were diagnosed with a defined CTD. And corticosteroid use was in 63% of patients in the Sebastian et al. Study, and death was reported in 29%. Coming to the Indian IPAP cohorts, a study from South India, hospital based, with They screened a total 14,000 patients attending the pulmonary medicine outpatient department, reported a prevalence of 0.17%. However, this is hospital-based single center study. The global prevalence ranges from 7 to 34%. So the other IPAP cohorts, the study done by Kasturi Hazarika in our center at King George Medical University included 35 patients. It was a cross-sectional study. The mean age was 51 years with predominantly females. Arthritis and Raynaud's were reported each in 31% of patients. ANA was positive in all patients at 1:320 titer. Besides anti-Rho, anti-CCP, anti-TRD synthesis antibody were also present. The cohort included NSAP pattern on HRCT in 77% of patients and also included UAP pattern in 20% of patients. Sarma et al. Similarly reported UAP pattern in their cohort 36% of patients. In addition, they also reported Zika symptoms in 32% of patients. So autoimmune features that are not listed in IPAP criteria also reported by Hazarika et al. With skin rash in 3 patients, non-specific skin rash, recurrent oral ulcer in 1 patient, periungual cuticular changes, and 3 patients had hematologic manifestation as thrombocytopenia. So, is IPAP a distinct entity? The available studies, the consensus of the available studies, I am aware of this study and expert opinion says IPAP and UCTD are clinical variants of the same autoimmune disorder. The study by Ferry et al. They compared CTD-ILD patients with UCTD-ILD patients with the IPA patient and IPAP patient. They found comparable clinical features among IPAP and UCTD-ILD patient, except the UCTD patient were slightly younger in age. The more frequently affected females, in their study it was 86%, and ILD less common in UCTD, but that can be attributed to a selection bias because ILD is the hallmark of IPAP classification. So, is IPAP criteria sensitive enough to pick up all aspects of autoimmunity? Zika symptoms were considered non-specific by the IPAP committee, but higher frequency of Zika symptoms in various studies. So, at least the objective demonstration of Zika symptoms in the form of thermal paste or unstimulated salivary flow could be included in the classification. Of course, inclusion of other autoimmune features required prospective studies, like RAS was reported, morbilliform RAS was reported in the Athens cohort. Our study also reported RAS in a small number of patients. Nail fold capillaroscopy could be included in the IPAP classification, but this can be helpful in patients with or without Raynaud's phenomenon. The French cohort particularly had 43% of patients had abdominal nail fold capillaroscopy. In addition, a rheumatologist reassessment is particularly important, is of utmost importance because when a rheumatologist sees a patient referred from the pulmonary department, there is a change in ILD diagnosis in 40% of patients and prevented 8 unnecessary procedures. Similarly, it was similarly reported in other studies. Then should UIP be excluded from IPAP classification? UIP was reported in various cohorts, and this is a recent publication, came in 2022 by Sambataro et al., who a study of 190 IPA patients were included in their cohort. 20% were labeled as EU IPAP patients satisfying one IPAP domain, and over 1 year follow-up, almost 29% of patients progressed towards a specific autoimmune disease. So they suggested, the author suggested morphological IPAP criteria could be removed. What about the serologic domain? And the ANA cytoplasmic pattern provides additional information, indicates a possible myositis. Anti-La has been seen in studies without, in the absence of anti-Rho, unlikely it is an autoimmune manifestation. And anti-synthetase antibodies could be removed, but that can happen after the classification criteria of myositis be revised. So my take-home message would be IPAP and UCTD are different clinical scenarios of the same autoimmune process, and IPAP criteria needs revision for recruiting homogeneous cohorts. Thank you.
That was a very elaborate presentation. Any questions from the audience?
So you told survival of UIP UIP pattern same as UIP.
Yes.
So in UIP pattern, should we ignore the autoimmune serology? We should treat them with strong immunosuppressors or not, or we should treat them on the line of IPF, anti-fibrotic.
So the retrospective cohorts, even or prospective cohort, when these patients satisfy fulfill the IPAP criteria, so UIP pattern was included in the cohort. Even if you look at the data from the Oldham retrospective cohort, the Chicago cohort, that included predominantly UIP patient, and they reported the UIP survival was similar to IPA patient. So if you see a patient, suppose C is at 65 or 70 or 70, and you are getting UIP pattern on HRCT, and you are getting certain autoimmune serology, so you might ignore those patients, or you have to go ahead with a biopsy to look for inflammation. But if you see a patient at 40s with a UIP pattern with autoimmune serology, probably you are dealing with a autoimmune pathology. So those are kind of controversial. Some studies say the UIP pattern even in biopsy shows plasma lymphocytic infiltration, and some says no. But the current evidence says with a UIP pattern, with a Arnhan says you have to consider it in a particular clinical context. Probably you are not dealing with an autoimmune etiology.
Basically, younger patient treat, elderly patient you should treat it as like
IPA, yes.
Thank you, Professor. We can have a Zoom call with them for questions if you have any.
The drug from the placebo, and we have done that in clinical trials by taking very early disease. By taking early disease and enriching for different factors, or like tocilizumab, a little bit longer disease duration and enrich for acute phase reaction. And what we have seen is something that is unlikely or unanticipated is the right word out here. So let me walk you through the phase 2 tocilizumab trial. What we showed out here is that this is a placebo group and this is the active group. But what I want you to focus on this placebo group. Overall, despite recruiting people within the first 2 years, there was improvement unlike the changes or the worsening that I showed you based on natural history. And then we look at the phase 3 tocilizumab program, and the same thing, you see quite a bit of improvement in the placebo group compared to what is expected on the natural history. People have called it placebo effect, people have called it regression to the mean, but is it really that? So let's look at some of the data here, and I'm showing you the placebo group. This is called a spaghetti plot from phase 2 and phase 3 program. What we are expecting people is to worsen out here. And what you're seeing here is that majority of the people, if not all, are improving as soon as they're entering into the trial. So you see a remarkable improvement in the placebo group, which is something that is really not expected out here. So I want to talk a little bit about molecular classification, and I think it's important to highlight the molecular classification out here, because at a phenotypic level, at a phenotype, scleroderma patients present with diffuse skin thickening with hand and large joint contractures. But at a molecular level, they have very distinct molecular profiling at a particular time. And it's very important to highlight at a particular time. And if you look at the molecular profiling based on the RNA sequencing, you see 4 distinct groups. The fibroproliferative group, which is seen in approximately 20% of patients with early scleroderma. Inflammatory group, which is deregulated innate and adaptive immune system, including interferon signature. And then there's a normal light group where the gene signature tends to be similar to people without scleroderma, and then the limited subset is restricted to limited cutaneous scleroderma. So we did a clinical trial with abacasset. I've presented this to my colleagues in India a few times, and this is what we expected in that trial. We wanted to recruit a patient with very early disease, progressive disease, and this is what we found. We found patients improved as soon as they came into the trial. But if you take the right patient at the right time and use the right drug, then you start to see very large clinically meaningful differences. So let me show you here. This is a placebo group on the inflammatory signature, in the inflammatory signature. And what you see, this is worsening, this is improvement, and there's really no change in the placebo group, and that's what you want. You don't want placebo group to improve. Whereas if you treat the right patient with the right drug, i.e. abatacept out here, you saw this remarkable improvement that is shown in purple out here in the active group with a delta difference of skin score of almost 8 scores. That's a very large clinically meaningful difference. If you take patients, wrong patient for the drug, i.e. fibroproliferative and normal life, you see quite a bit of noise without differentiating the drug from the placebo. And then, of course, there are autoantibodies that are critically important, and autoantibodies are mutually exclusive. And in clinical practice, if there's one message I can relate to you, autoantibodies are much, much, much more important compared to classifying patients into diffuse and limited scleroderma. We know that 40% of Indian population who are topo or SCO70 positive tend to be limited cutaneous, but they have high risk of lung fibrosis. If you are anti-RNA polymerase III antibody, higher risk of scleroderma crisis and diffuse disease, and anti-centromere antibody, of course, we are well aware of.
Email in the questions if you have any. I think we had a third talk in this session by Dr. Pradyut Mahapatra, but unfortunately he could not make it. And I think Kaushik is here, probably is filling in for Dr. Mahapatra. Good. So Dr. Mahapatra couldn't make it, and I'm really thankful to Dr. Kaushik Bhujan. He's coming all the way from Bombay, and he'll be taking an interactive session on interstitial lung disease. Orator, over to you, Kaushik.
Thank you. I'm sorry I'm filling in last minute. I just rushed in from my last talk. My talk was supposed to be 4:25 to 4:40 in the earlier one. And so what I thought was I would deliberate a few things in terms of scleroderma. This entire talk, though I mentioned autoimmune lung disease, is related to scleroderma. And of course I will skip a few of the GI manifestations which do seem to contribute to the lung dysfunction as well. So we won't talk about the reflux and so on. I just want to talk about my thoughts, and I'd like people like the bright ones like Kunal and so on, and all of you all to be able to give me your thought process on this one. So we all know that CTD-ILD accounts for about 10 to 20% of the non-specific interstitial pneumonitis, and we also know that the rest of them are sometimes unclassifiable if you take away the UIPs, and there's hypersensitivity pneumonitis. So this is data from India which confirms that we are more or less in concordance with the incidence of connective tissue related ILD to the tune of 15 to 20% internationally, and ours was 19%, and this was a retrospective analysis, multi-center, 27 centers across 19 cities. And what we looked at was the incidence of NSIP was 54%, which is where the prototype of systemic sclerosis comes in. Now, if you go back to this very old paper, it was said that non-specific interstitial pneumonitis seems to have a better prognosis than usual interstitial pneumonitis. The question to ask is, then how is it that our scleroderma patients are not doing too well? And that's because if you look at this paper, 2005, you will find that non-specific interstitial pneumonitis due to other causes and not connective tissue diseases, the prognosis is better. Whereas our 5-year survival, if you had a CTD-ILD, was 43%, less than 50%. And of course, everybody knows about the fact that it goes back to the criteria of Go et al. And Sujal Desai and so on, who's looked at the radiographic scoring and come up with the fact that, the fibrotic score decides the prognosis. So look at this. If you look at this part of the paper, what you will realize is that CTD-ILD has a large number of usual interstitial pneumonitis pattern rather than an NSIP pattern, which is why the overall CTD prognosis seems to be poorer. But what's also interesting is that what you classify as interstitial lung disease because of scleroderma in an NSIP pattern, have you considered the fact that if you actually sit on the radiographic scoring, and I'll come to that, a lot of it, what you consider as ground glass opacity is followed by fibrosis, is actually microfibrosis, which looks as ground glass opacities on the CT scan. Now that's not going to respond to your immunosuppression, and that is the humble submission that I want to make in this little talk, and I seek your wisdom on my thoughts. So this was the UDAR Scleroderma Trial Research Group database across 102 centers in a large number, and if you realize that the lung and the skin matched, and all of us know this, that I mean, this is raw, the survival estimates based on a single cohort to the royal-free cohort, the Chris Denton group, also showed that if you had diffuse cutaneous systemic sclerosis, then your prognosis, long-term survival was lesser. Now, this is what I have been doing with all my patients, a quantitative scoring. This is way before COVID scoring came about, and this is based on the SLS study 1, based in 2006. So I get my CT scans quantitatively scored manually to look at divide the lung into 3 zones, the upper, lower, and the middle zone. And then you look at the percentage of fibrosis and then decide as to how are you going to treat this patient. So I'm going to give you a case in point. This was a 53-year-old lady from Assam. She was diagnosed as a systemic sclerosis with ILD. She was on mycophenolate and she continued to have fatigue and dyspnea on exertion. She had come to Mumbai and she had met a pulmonologist and taken 3 pulmonology opinions in Mumbai before I don't know how she ended up on my lap. But there were 5 HRCTs over 2 years and all were diagnosed as NSIP, reticulations and some fibrosis. And the pulmonologist had stepped up the dose of mycophenolate, but she continued to have function class 2. And so I got them quantified in the fashion that I saw in the HSCRP was high, and I put her on tocilizumab, and there was a dramatic response in the function class improved and so on. And the ground glass opacities actually improved. Mind you, I don't claim any credit here because this raised all the more questions, and these are my doubts that I have. Unlike UIP, the radiological diagnosis of NSIP may have a lot of inter-observer variation. And how are you going to deal with it when the NSIP can be cellular or fibrotic? So you need to determine how much of it is fibrotic, because the fibrotic NSIP could be the left hand of the spectrum of a UIP. And for that, you need to quantify the component of inflammation. And what you have right now, what you have is possibly a CRP, and what you have is in some cases in patients who agree, you possibly might do BAL and look for the inflammatory cytokine milieu and hope for the best. That's all that you have, isn't it? Now, a fibrotic lung, doing a BAL is not exactly the easiest of options, particularly with a microstomia and so on. It's difficult, right? Now, you look at the fibrotic scores and you don't know what you're dealing. So if the score worsens on treatment, do you know afterwards when you do a sequential CT scan, you realize, oh shit, I treated the patient with immunosuppression and the lung is worsened, so maybe this was all fibrotic. And so we are playing guesswork in terms of scleroderma and ILD. I don't really see the evidence-based medicine that we talk about in all the other diseases as far as this is concerned. So we talk about if required in the algorithm in 2018, this is a recent review, and they've shown if required do an invasive evaluation with a biopsy. So my humble take home here is that I will skip this because this is not really relevant now, but I'm going to show this case and that will be my take home. This was a 57-year-old construction engineer post-CABG status, husband of an anesthesiologist, and 9 months post-CABG he had fever, anorexia, weight loss, and the HRCT showed some ill-defined lesion in the upper zone. And the P anchor was positive, which is why I was referred, and I said this P anchor has no role. And I got a BAL done, which showed galactomannan high levels, and so the patient was put on voriconazole, and I thought I was done with this case and over and dusted. But the patient came back to me 3 months later with neck pain simulating carotidynia and recurrence of these symptoms. And the anesthesiologist's wife had gotten an MRI of the neck done, which showed some perivascular stranding. So it ball again came in my court, saying that the P anchor was positive and there's some stranding around the IJV. So this is vasculitis, and you're not treating him. And I wasn't convinced. So I got a PET done, which showed extensive nodules in both lung fields. The PET specialist said this is sarcoid. The radiologist on CT scan also said, yes, this is sarcoid. And the transbronchial lung biopsy was abandoned because he had excessive bleeding. So eventually, after giving him whatever, correcting his coagulation abnormalities, we got a video-assisted thoracoscopic biopsy done. This is what it looked like. And so everybody turned around and laughed at me and said that, look, this is sarcoid. You didn't have to do a biopsy for this, right? The beauty is the histopathology showed fibrosing alveolitis, no granulomas on any section of multiple sections taken. Patients were started on steroids and mycophenolate. I saw him last month, he's much better. What I'm trying to submit out here very humbly is that there is a role for tissue when I see a CTD-ILD as well. I want to know how much is cellular. I want to know how much is fibrotic. I want to know whether this is really a fibrotic LSIP which would change my plan and thus the long-term output. Thank you very much.
Thank you. Very nice presentation. Any questions?
Yes, ma'am.
Is there any role of FDG PET in determining inflammation versus fibrosis in SSCIA?
So I have been asking this question to the radiologists, and as you can see from the last PET that was shown, it doesn't seem to be that great in terms of the ILD pattern of fibrotic versus cellular in terms of uptake, the way you see it beautifully in the different organs in terms of the SUV values. You don't seem to see that in the lung. It's similar to, for example, giant cell arthritis. If you have temporal arthritis, a PET scan is not very good. So I'm not very sure whether at the microvasculature level, whether a PET really reveals anything. But yes, I do believe that even if it showed inflammation, the challenge is, many years ago when I started working in scleroderma, the first question that I used to ask myself is that I see a patient with ILD scleroderma, and I think that this seems to be acquired disease, and I have managed to get it. In those days, there was no mycophenolate being used for scleroderma, of course. I'm a little old. So what used to happen is azathioprine, high-dose steroids, and I'm one of those few freelancer idiots who also tried imatinib for ILD and scleroderma back in 2008-9 based on Frederick Wiley studies. So I've done all of that musty in my life. But I never understood where to stop. I never understood where to upgrade. And I would just see a serial CT showing some worsening. And I didn't know what to do. Of course, nobody was using PETs in those days. But even now, I don't see PETs showing anything in terms of fibrotic versus cellular NSIP, or showing me some inflammation in terms of alveolar. Yes, sir.
Excellent, as usual. So my question is that histopath agreed is a very useful tool to get information for the fibrosis as well as the cellular component. But being invasive, it's difficult to get it done. So is there a role of volumetric CT analysis showing amount of fibrosis? Is there a role of that as compared to the vital capacity?
Thank you. So I have been doing only volumetric scans. So let me tell you the protocol for looking at ILD. ILD study doesn't involve a CT scan straight through. What you need to do is 1 millimeter cuts with inspiratory, expiratory, and prone images. And this is not my data. This is been proven by the international guidelines. So you're supposed to do volumetric. The challenge, my friend, is that what looks like a ground glass, even on an inspiratory scan, might just be microfibrosis. And you're going to realize it only when it solidifies into reticulations. What we're discussing out here is that why are we having a lower, a worse prognosis, a lower successful outcome, despite the fact that we've gone from having no treatment all the way to biologics, and we still seem to be stuck. We don't seem to get the same beautiful results that you get with biologics in RA, biologics in angst, biologics in other diseases. Why don't you get it in lung outcomes? Why is it that the CTD-ILD seems to have a bad factor if it is all NSIP? Why is it that the Scleroderma-Myositis seems to be more like a UIP with a downward progression, which is because we are missing the boat somewhere? Should we be starting the antifibrotics first and not wasting our time on looking at mycophenolate because it's a fibrotic NSIP? Versus, should we be empirically treating, just hoping that everything is alveolar and microfibrotic and just shoot in the dark? So mycophenolate de do, nintedanib de do, sab kuch de do, you know, like the GP kind of treatment. Treat every fever with every antibiotic, anti-malarial, steroid, everything together. Kuch to treat kaam karega. So there are two ways to do it. Unfortunately, if you don't have an endpoint and you don't have a benchmark, you don't know when to stop and when to escalate. That's my solution.
The project, nice presentation. What is your how do you decide on giving tocilizumab or rituximab in systemic sclerosis ILD? Generally, in my experience and what I have done in the past is always given rituximab for most of the patients who have ILD. So how do you decide and how do you go about it?
So thank you. So the challenge here is that we are looking at one arm. Now, if you go back, see when you talk about the biologics, you automatically need to talk about the fact that the immune arm, and you need to talk about the T cell versus the B cell and the retux, and everything is interrelated. So when you say rituximab, which means B cell, you automatically are affecting the T cells in some way in a backward fashion. The truth is that the T cells are those which activate the B cells. Now, somewhere along the way, you have the IL-6 and an interleukin in a loop which works on both sides of the arm. So one might activate the other, and it might work in reverse as well. Honestly, currently there has been no comparative trial between rituximab and tocilizumab, so I will only submit what I am finding out here. I don't seem to see very great results as far as skin is concerned in rituximab, but there's definitive data in terms of MRSS improvement if you have skin. So if you have skin progressing and if you have a relatively early edematous skin, you're very lucky. Most of the times this patient has gone over the world, done Ayurvedic treatment, then come to you. So it's very thick and difficult for you to really rely on your MRSS. So if you have an elevated CRP, if you have inflammatory markers, if you're seeing that the skin is inflamed, you're lucky enough to see that along with ILD, I might place my bet on tocilizumab. The challenge is India. And I don't use the Fascinate trial dose of 162 milligrams subcutaneously every week. That's hopelessly expensive. I have not understood how this company can make a fool of everybody in this country by giving the same amount of dose in pre-filled subcutaneous syringes and charge it at 88,000 rupees a month, whereas a 400 milligram dose IV will cost you 40,000 rupees a month. So they think we are idiots. So I don't do that. But if I want an acute response, and if I see a patient is acute, so for example, the lady from Assam, okay, let me take that. This lady, I needed to cut short, and so I would play a game with her. This game was that she had progressed. She was going down in terms of a lot of MSK symptoms. She had a gradually progressing ILD. She had a lot of skin. I chose Tossi. Now my own patient, who is currently the patient leader for the Scleroderma group, the patient group in the country, she essentially never had too much of skin. She used to have this severe Raynaud's, and she straight away progressed to edematous skin, but she never became fibrotic. She's obese, she straight away started having lung manifestations, and she got ground glass opacities, and then she got a boop. And then there was progressive ground glass opacity. So that's where I banged with rituximab because I didn't have to worry about the skin. By and large, I don't see great results of rituximab and skin, and it's late acting. So you take your call depending on how quickly you want action, number one. Number two, what are you targeting? I've just treated a lady with scleroderma-RA overlap with a disabling RA. And there it didn't make sense for me to wait for rituximab to work. And so I've given her Tossi now with the caveat that I'll give it to you for 3 months, let my methotrexate and everything work. Once you're stabilized, the long-term plan will be redux. So I sometimes play this game with a window period in the middle. Really, there are no clear answers on this one. The standard guidelines way before they published, and I don't even know why I was doing that. I have no clue how I designed them. So it might sound very pompous, but the truth is that when the guidelines came out, I felt very validated. So I do my 6-minute walk test at every visit. I do my PFT and a stress echo every 6 monthly. And after that, I do an HRCT annually. Because we know that the PFT and the HRCT may be discarded often enough depending on the compliance of the patient, non-compliance, breathing exercises, musculoskeletal manifestations in terms of the ribs, and so you don't really get a correct picture with only the PFT. So this is what I do, and this is what I've been following for about 11 years now, 11, 12 years.
I think Kaushik, I was wondering about the worth of the whole day MRI scan, and from your talk I realized that you go deep into your HRCT of other patients, devise some methods, and it really helps you along with your ready level, of course. But I mean, that was one take-home message, that we should get acquainted with other investigations as well. Thank you for that. So I think